Hi, Mike Gibson coming to you live from TCT 2024, and I'm joined by Birgitte Krogsgaard Andersen. Welcome.
Thank you
And,
very much.
and Niels Holm. Something near and dear to my heart, coronary blood flow. You're looking at the first comparison. This is the first comparison of angiographic derived QFR versus FFR. So I'm really excited to see what you did and what you found.
Thank you very much. So we did this study, the FAVOR-3 Europe trial, and it was the first randomized trial comparing clinical outcomes following a QFR-based diagnostic strategy and an FFR-based diagnostic strategy. So quantitative flow ratio, or QFR, is this estimation of FFR, computer-based estimation based on analysis of angiographic images. And with FFR, you need to use a coarsely pressure wire, and you need to give adenosine, and with inherent risk and side effects for the patient. And this is not the case with QFR. And therefore, this technology, which has shown promising results already, has the potential to lower the costs, but also reduce patient risks and discomfort. So a large body of evidence is already available for QFR. A meta-analysis of prospective studies with paired assessment of QFR and FFR showed a good diagnostic agreement with FFR. Most importantly was, however, the FAVOR-3 China trial, showing that QFR was superior, clinically superior to a standard angiographic guidance. These results supported the recent European Class 1B indication for QFR to guide revascularization. So present trial that we just presented at TCT 2024, the FAVOR-3 Europe trial, we compared QFR to FFR. And as FFR has a 1A recommendation in both the European and American guidelines, it was a non-inferiority design aiming to show that QFR was as good as FFR. So we had the pleasure to...
How well powered were you, Birgitte, in terms of the study? How many patients did you have? Event rates you thought you were going to have? Were you adequately powered to answer the question?
Yeah, so we calculated that we needed 2,000 patients and estimated an event rate of 6.7%. And we actually had that event rate in the QFR group, and we did not reach that in the FFR group. So of course we were looking into that, but when we saw the results, the primary endpoint of 1 year MACE consisting of death, myocardial infarction, and unplanned revascularization, we had the power to evaluate if it was non-inferior or not. And what we found was that QFR did not meet non-inferiority to FFR.
Was FFR superior to QFR?
Well, we did not have, the trial was not designed for that, so we do not have power to conclude that. But there was a statistically significant difference in the rate of MACE between the two groups.
In favor of FFR?
In favor of FFR, yes.
And what drove that? Was it death, MI, or revas?
Yeah, so the difference was mainly driven by a higher rate of myocardial infarction and unplanned revascularization in the QFR group. So the difference in myocardial infarction itself was actually significant.
Did you intervene upon fewer patients in the QFR group? Was it the fact that you just didn't treat as many lesions that led to more MIs and revasc?
Actually, we saw a higher rate of treatment. So 21% more patients which had a study lesion treatment. So one of the lesions that were measured with QFR or FFR was treated for 21% more patients in the QFR group, and 27% more stents were implanted.
So when you talk about higher MI rates, were those mostly peri-procedural MIs in the QFR group?
So we did a post hoc analysis taking these peri-procedural MIs out, and even taking these out, the result for MACE remains the same. So it's not driven by peri-procedural MI either.
Wow. Well, Niels, what say you? What do you think of these results?
Well, I think these results, as you implied, they were a bit of a surprise. We had this substantial body of evidence pointing in a direction that was quite favorable for QFR. We saw early on that the diagnostic accuracy was at least at the same level as IFR with FFR as reference. So we were quite encouraged when we started out on this trial that we will had at least non-inferiority and maybe a quite balanced study. But that was not the case, and this is why we do randomized trial in a multi-center clinical setting. Yeah, of course, randomized trial is a descriptive trial, and now we need to look into the more mechanistic part. Why did we end with an inferior result with QFR?
So do you think this is a problem with the hypothesis that angiographic QFR is not as good, or is this specific to the specific system that was used or software? It seems as though it may go against the hypothesis itself.
Yeah, so there could basically be two things wrong here: that the software is not good enough, or we didn't use it the right way. And that's of course what we're going to look into now in more details. And there will be reanalysis. We will look into the quality of the analysis that was performed, and in that aspect, we'll try to report as soon as possible. What could be the circumstances that caused this inferior result for QFR.
So at this point, do you think it'd probably be best if people used FFR until this is clarified?
Yeah, I think that with the favor-free China result, we can be quite confident that QFR is a better option than pure angiographic guidance. But if you do have FFR available in your cath lab, that's still the number one tool. I think that's the most appropriate interpretation of the results right now.
Right. So FFR is king, and only use this if you don't have access to FFR.
Yeah.
All right.
That's probably also the case in many countries. Now we are, you're in US, we are in Europe. Most countries can afford using pressure wires, but many countries across the world, QFR may still be the best option for the patient there.
Great. Well, final words from you, Birgitte?
Looking very much forward to these coming months of further analysis into the data, and to present to you also hopefully mechanistic explanations. But for now, these are the results, and even though it may be disappointing in terms of what we expected, these are the data.
This is why we do trials.
Yeah.
All right. Well, thank you both. Thanks for taking time out, and thanks to our audience for taking time out to listen to us today here live from TCT 2024.